kind of weird when you're in this small of a group. So it's my great honor, actually, to have over officially Ronnie, right?
Yeah, Aaron, Ronnie, whichever one, yep.
Yeah. Who is an associate professor here in the Fuqua School, and is also performing this year as a visiting professor at Harvard, where he's also teaching in the business school, is a remarkably great speaker. So I'm not going to take any of his time. I've seen him speak several times. It is probably one of the best speakers you'll have around. No pressure.
No pressure, yeah, I guess that's...
But yeah, go ahead.
Thanks so much. All right, well, with that introduction, Eric always likes to set me up for failure. You know, that's good. So how can I surpass that? One of the best speakers you've heard in a while. So hopefully you haven't heard too many talks in a while, and there won't be much to compare me to. So innovation, entrepreneurship, and the U.S. healthcare system. One trademark is I always try to put up a title that I can't possibly deliver on, because these topics are so broad that I don't think I could fill this in 10 hours, much less 1 hour, and get to your questions. But these are the kinds of things I'm doing research on over at the business school. I've been at Duke since 2006, and for those of you who are junior faculty in the room, when you first start off at a position like that, you spend a lot of time getting to know people in your own unit. So for me, that's the group of scholars, about 10 or so, that study corporate strategy, innovation, entrepreneurship. We're mostly a bunch of economists and sociologists. And then after a couple of years, you sort of pick your head up and think about the broader school that you're associated with. And for me, that's the business school at Fuqua, 100 faculty in areas like marketing, finance, accounting, organizational behavior. As I started to get to know people there, one day you really pick your head up and stand up and say, well, I can walk around this great campus at Duke and learn all sorts of things and go to all sorts of different departments and talks. And so I've been spending the time since tenure last year just trying to get to know people around Duke. And DCRI is part of that for me. A lot of my research is about innovation and entrepreneurship in the healthcare industry. So for me, DCRI is a great place to connect with. And there's so many departments on campus that, you know, I barely knew people until I started to kind of poke around and go to seminars. And I hope these collaborations will be useful for me and people on the other end. If I can be a person that's helpful to people in the room as you seek to connect to the business school and also the business community in Durham, I'd be glad to avail myself for that. I think one of the great things about the Duke community is we can have these kind of partnerships, and hopefully they flow pretty easily. So let me just give you a quick background. Who am I? Why am I here? I looked at your YouTube page with the previous talks, and I happily concluded that I don't think you've seen a single talk that's really like mine, so I wanted to give sort of some background. So for political buffs, that's Admiral James Stockdale. I don't know how many people remember. He participated in the 1992 vice presidential debate, also a war hero. And so what Admiral Stockdale, who was a war hero at that time, came on the stage and said, who am I? Why am I here? He was kind of a dark horse vice presidential candidate with Ross Perot. And so I kind of feel like I need to do the same thing here, given that you might not have seen someone in my background give this kind of talk. So I'm an economist. I study entrepreneurship and innovation, most of it in the healthcare sector, but not all of it. So I'm really doing a lot of work now across many sectors in the U.S. economy, most of my work based in the U.S., and now starting to venture a little bit out into international economics. I've been at Duke since '06. I've taken 2 leaves from Duke during that time, so that's pretty generous. So I should thank President Broadhead and at the time Provost Peter Lang for those. In 2010 and 11, I worked for President Obama at the Council of Economic Advisors, one of 7 senior economists working for the chair, Austin Goolsbee. I've been involved in politics and policy for a long time. Working in the White House was a great experience. I covered entrepreneurship, innovation, business. For people in the crowd, one of the interesting things that happened during that time was I arrived at the White House just after the Affordable Care Act was passed. And we were switching over between health economists. I was not a health economist. I'm not a health economist. Mark Duggan was returning back to the Wharton School of Business. And there was a gap. And so they needed someone with some knowledge of health to go to the meetings to discuss the Affordable Care Act. And at that time, those meetings were led in the White House by Nancy Ann DeParle. And so I got to go to those meetings for about 3 months over the summer as we were transitioning between health economists. And I learned a ton about insurance markets, different provisions of the Affordable Care Act, things that I read about today in the newspaper that we were talking about then. Very, very useful. I got a chance to meet a lot of industry folks during that. So Karen Ignani, who's one of the big lobbyists on healthcare issues. That's a person we dealt with a lot. I also dealt a lot with the FDA, given my interest in innovation, meeting with Peggy Hamburg and Jeff Shuren at CDRH and FDA proper. So that was a great experience at the White House. Came back in 2011 to Duke, and then proceeded to go on leave again in 2014 and 2015. got tenure, went to Harvard Business School. I'm still officially there until tomorrow, and then I'm officially back at Duke as of July 1st, but moved back at the end of May just because I've been commuting as my family stayed behind, so it was good to get back. So that's what I've been up to since I got to Duke, and the teaching and research is all really focused around entrepreneurship and innovation. Most of my work is empirical, using large data sets. I do a little bit of theoretical work with co-authors, but most of it is empirical, using big data sets like the patent data or the FDA data or data scraped from the internet. So there's lots of different data sources I'm working from in healthcare and otherwise. I can talk a little about them as we go on. Most of my outlets, strategic management and economics journals. I publish a little bit in health affairs and some policy journals as well, but mostly involved in strategic management and economics and continuing to do so. A few big picture activities, mostly not writing about health actually, but writing about the broader economy in the New York Times and the Wall Street Journal. A few exec ed talks from time to time with medical device firms, because that's where a lot of my work has been. And currently working with a few companies in Durham and around the country as a board member and trying to help them navigate the treacherous sort of path to navigating the valley of death and becoming a successful startup. So that's what I've been working on as well. So that's kind of a background of who I am, what perspective I bring here. Definitely looking forward to learning a lot. So you don't need to save your questions for the end. With a presentation like this, when you present to a new audience, sometimes there'll be things on the slide that I surmised weren't going to be very interesting to you, and they might be the most interesting thing to you. So feel free to raise your hand and tell me. And there might be things that I belabor because I figured you'd be very interested in them, and it turns out that it's all old hat and you're not very interested in them. So feel free to raise your hand and tell me to speed up or slow down as we go through. So here's what I want to do for today. I always set out goals for today's talk because sometimes the goals of the speaker and the audience are different. So here are my goals. I want to provide some of my high-level thoughts on what innovation and entrepreneurship mean in healthcare. These words get bandied about a lot in the business school, and I imagine over here and in the popular press. And I wanted to give some context on how I'm thinking about innovation and entrepreneurship in healthcare. I want to give some big picture illustrative examples that I've discovered in my research, that I've kind of found in the popular press, that I've written about. I then want to focus narrowly then on two projects that I'm doing on innovation and conflicts of interest. Obviously, this is a hot issue for the physicians in the room, especially. This is something you talk about a lot. I'll give you kind of an economist perspective on conflicts of interest in innovation. I've also been reading the series in the New England Journal by Lisa Rosenbaum on conflicts of interest that's brought this issue to the fore again. So I'll go into that and show you some of my data and descriptive statistics. And then hopefully I can provoke a discussion about the future of the US healthcare system, what role innovation and entrepreneurship might play. Here are your thoughts. One thing I find very useful when I talk to companies or people outside my field in general is you get your best research ideas when you talk to real people. And I think that's like a fantastic way to think about a research agenda. When you actually find the questions that people are asking day to day in practice, it turns out those can be the best questions. Too many academics, I think, formulate questions in the ivory tower without thinking about whether the questions are actually interesting to someone who's really making a decision. So I hope you'll give me a sense of the questions you're struggling with as you work in your research and your practical work. So let's start with disruption. So I meet people every day who want to disrupt healthcare. They want to disrupt healthcare. That word comes from Clay Christensen's Innovator's Dilemma, a famous business book that's now been read by millions of people. And most of the time, they really scare me because I think they have no idea how healthcare actually works. I've been studying this stuff as an outsider for 9 or 10 years, and even I am just always astounded about how complex it is. When I sat in those meetings at the White House and I heard abbreviations that I've never heard before or since, I realized that there's so many parts of this system that are just basically opaque to anyone who's really not deep into it. And when people tell me they're going to disrupt a very complex system, whether it's healthcare, whether it's education, whatever it might be, I always pause a little bit and take a deep breath and wonder how that's going to go. But the momentum is sort of against me because innovation and entrepreneurship, I kind of look at these as the toolkit. This is where reformers and idealists all around the world, not just the United States, are drawing from to change systems that they think need reform. And healthcare is no different. So if you look at this, like the answer to every question that my students at Fuqua and at Harvard Business School are asking, I mean, these are the questions that millennials are asking, right? How do we address global climate change? How do we solve world hunger? How do we fix education? How do we make government more efficient? How do we bend the cost curve and increase quality in healthcare? These are the questions that every single one of my students want to know the answer to. And the answer is entrepreneurship and innovation. That's been the answer that they've given me. And the question is how, why, what's at the core of this? Because it's easy to have buzzwords. It's a lot harder to figure these things out. So let me tell you how I'm thinking about this. So let me start by saying innovation and entrepreneurship are powerful forces in the economy. They're not oversold in a general sense. They account for a large share of economic growth. The creation of new products, new companies, this is what keeps the US economy, for example, on the cutting edge. We're creating products at scale now that we couldn't even imagine just 10 or 15 years ago. If you look at advances, for example, in machine learning, computers can do things now that were literally science fiction 15 or 20 years ago, and that's amazing. If you think about the smartphone in your pocket, I'm going to hope it doesn't come out of your pocket during the talk, but as you think about the smartphone in your pocket, think about all the things it can do. It's your map, it's your clock, it tracks your investments, right? It communicates with people. It does the work of 10 to 15 other devices all in your pocket at a computing speed that was probably superior to what they had in Houston when they put a man on the moon in 1969. It's probably more computing power than what they had at NASA. Okay? So that's how we're thinking about this. Okay? Now, can we break the quality cost trade-off by finding a better way? That's the holy grail when people apply this lens to healthcare. And maybe we can bring a productivity revolution to healthcare. See, I mean, this isn't without precedent. So these people who talk about this, what they're thinking about, the analog is what we did in manufacturing, what we did in retail, what we did in finance. In all those sectors, we found ways to adopt new technologies and increase productivity. And people are looking at healthcare and also education, which is a passion of mine, with the same lens. And so I think the picture is something like this. This is how we used to make cars in the early part of the 20th century, and this is how we make cars now. And for the docs in the room, I think you're the ones with the hats, right, over here. In fact, Vinod Khosla, prominent venture capitalist, estimated, I think, around 80% of doctors he believes will be obsolete because of advances in technology. 80%, right? That's a new version of when you start medical school or law school and they say, look to your left, look to your right. You know, one of these people is not going to be around. Now, and I don't mean to pick on the docs because, by the way, professors like me who teach at business schools, we're also in the hats there because everyone wants to replace me with a MOOC, right? A massive open online course where instead of listening to me, they'll just take one professor and beam it to everyone around the country. So I'm also worried about being the guy in the hat. But the question is, right, is this the future of healthcare? I mean, after all, right, our manufacturing sector, I mean, don't get confused by all this stuff in the media. It's the most productive it's ever been. We are the most productive manufacturing economy in the world. We produce more stuff at lower cost than anybody, and our goods are much better than they were before. What's the difference? Far fewer workers. Far fewer workers. That's the difference. The guys in the hats are missing, right? So when people think we don't make stuff in America anymore, the rejoinder should be, yeah, we make a lot of stuff. We just don't make it with as many people. In fact, there's more people on Social Security disability insurance now than work in our manufacturing sector, right? Which is a comment of a different kind. But here, people are using this model and thinking that we're going to replace doctors with tablets, teachers with robot tutors, and we're going to have a world that looks like this, and we're going to save a lot of money. This is a lot of the logic behind the innovation entrepreneurship meme. So maybe, right? I'm not a Luddite. I don't think that we should reject these ideas out of hand. But the things I've been considering a little bit in my research and some of the big picture writing is the following. Human interaction and judgment matter a lot, both in healthcare and in education, the two sectors that have kind of been left behind by the productivity revolution. I don't know if you can replace that with machine learning yet. I also think that there's a sizable public sector involvement in both of these sectors, especially healthcare, where it might make it hard for some of these things to be adopted. In fact, there's different objectives, right? Access is so important for healthcare and education. That's why the public sector has been such a big part of both places. In other areas, that's not necessarily as important of a priority. There's also a lot of history. You know, people talk about technological revolutions. So my daughter has an iPad in the classroom, but I had a PC in the classroom. And a generation ago, there was another technology that came into the classroom. Same thing in healthcare. There's been lots of technologies in healthcare. The problem is when we study them, a lot of them didn't always reduce costs. And in fact, there's been tons of experiments with technology in the classroom and in hospitals, and we've seen that they haven't always delivered on their promises. And one question you might ask is, what's going to be different this time with this new revolution of innovation and entrepreneurship? Is there something special about mobile apps and wearable devices that are going to make this different? The other thing I'd like to say, I think it's facile to think that technology and humans are substitutes. Economists think about at least two different kinds of models, right? One is where labor and capital are substitutes. That was the manufacturing picture I showed you before. We replaced workers with machines. The other one, which people don't talk about as much, is complements. That is, I add more technology and I need more people. This, to me, seems a lot more like what's going on in healthcare and education. I need someone to read the screen that I have this new device producing. I need somebody now that I have some of the kids on the iPad to think about the pedagogy that's going to go into it to deliver the adaptive learning experience. But that's a much different proposition. If we add people and technology at the same time, we might get better outcomes. But we might also add more middle-skilled jobs and add cost. So a lot of the promise about bending the cost curve seems to assume a substitution between technology and people. What I see in education and healthcare both, and I'll talk more about healthcare specifically, is more of a complement story And I don't think necessarily it's going to work out the same way that some of the sort of most optimistic people think. So that's some of the things I've been thinking about. The other thing is fidelity of implementation. I work with so many healthcare startups that have great ideas. And if they even get to do a pilot at a great place like Duke or UNC, they often find that they're disappointed. It's so difficult to actually implement these new technologies, right? I mean, think of even if you had a newfangled gadget that actually worked, you have to find an FTE in the hospital to actually look at the screen and act on it. And after the technology works, they have to buy it, and then that person has to stay employed doing that job and looking at that screen. Even that, at bare minimum, is difficult, much less something working in the wild, right? It's much easier for these technologies to work in isolation than in a real organization. So fidelity of implementation is a bigger challenge here than I think in a lot of other sectors, and that's another thing that's holding some of these things back. So what do people mean then when they say innovation and entrepreneurship in US healthcare? I put a non-exhaustive list together because I don't spend every day thinking about the list, but I think you guys might have things to add. Here's what I think. New pharmaceuticals, biologics, diagnostics, devices. This seems to be our standard ones we've been thinking about for a while. I think new ways of organizing and delivering care. That's some of the stuff that came out of the Obama administration with the accountable care organizations. The application of technology to inform both clinical research and decision making. So I think the EHRs, there's a great article in the Washington Post about Watson, the IBM computer now turning its attention to solve puzzles in cancer. New ways to measure drug safety and efficacy. I think I'm at the ground zero for that with adaptive clinical trials. New consumer devices like Fitbits, which I'll talk a little bit about in a second. And new mobile apps like Blue Star, which to my knowledge was the first app approved by the FDA in the treatment of diabetes. Then there's new startups, and there's new units in large organizations that are going to invent and commercialize these things. I think this is what people are thinking about when they think about innovation and entrepreneurship in healthcare. So what's the theory of the case? We've had a bunch of good Supreme Court decisions coming out for us to sink our teeth into, right? What's the theory of this case? First, we're going to figure out what works. Oh, that's easy. We all do research, so we'll be able to figure out what works pretty easily. Then we're going to align incentives for adoption. We recognize that's pretty hard, but once policymakers and people who lead institutions know what works, they're going to want to spread it. Then we're going to scale, right? Because that's natural. Everyone will have the incentives to do it. And then we're going to rinse and repeat and do this with all the great healthcare innovations. And that's how we're going to make progress on these kinds of things. As I hear and articulate that theory of the case, I think there's a lot of problems with it. And I think there's a lot of reasons why it's not going to happen. So let me tell you what I think about it. So it's going to be hard. That's the first thing. I think people think these kinds of things are too easy. And I think people with a lot of experience in the field will kind of tell you that as well. First of all, figuring out what works isn't easy. We're all researchers in this room. And study design and replication are big challenges. Think about the kind of work that I do over the business school and how it might be different than some of your work. One is I can't always run RCTs. Okay, I have run a couple large-scale field experiments at Fortune 500 companies, but it's very, very, very difficult to do. So if you're thinking about how organizations adopt new technologies, if you're thinking about how to change a big hospital system, running experiments, running RCTs, coming to the gold standard of proof, very, very difficult. Okay, and that's not necessarily going to change in this new world that we're talking about. Second is, what about effect sizes? Right? A lot of times I'll find an effect size, and the size is not economically significant. Right? It might be a 2% increase in some metric, but it's certainly not worth the cost that I spent to get it. There's a lot of great interventions right now in healthcare and in education that I think fail that test, where the effect sizes look positive and statistically significant, but I wonder if they're economically significant. And I wonder, even if they are, if they're worth the money that we put into it. And so when I hear about programs, that's sort of the first question I'm always asking, is more about the cost-benefit trade-off rather than some sort of a bunch of stars on a coefficient in a regression. External validity is also a big deal. If something works in Portland, Oregon, or Durham, North Carolina, is it going to work somewhere else? We're trying that actually in education. For those of you who live in Durham, the Harlem Children's Zone is one of the successful education interventions in Harlem, New York. They're bringing it to Durham, and it's called the East Durham Children's Zone. And they're trying to replicate it. And the big test here is external validity. Is what worked in Harlem, the same program going to work in East Durham? Well, I'll tell you one big difference, right? In Harlem, you have a bunch of people in a 100-block radius who are walking places. In East Durham, right, a lot of people, right, can't necessarily walk very conveniently between the different community centers. That's a big thing you need to think about. And that's the kind of thing that could really change the results, because a lot of what the Harlem Children's Zone is doing in education and in health is meeting pregnant women, right, before they deliver the baby and saying, here's the things you need to sign up for. Here's the services you need to get. If you don't have that flow of people, it might be very difficult to execute. Now, the people at the East Durham Children's Zone definitely know that. But external validity is a big issue when you think about these technological interventions. And that's one thing I've been worrying about. When you think about organizations like DCRI or others, how do you set up a culture that facilitates experimentation? Well, it sounds easy, right? You hire some consultant, you form some sort of group that's going to think big things and be undisturbed by the bureaucracy, and then you experiment and innovate, and everything takes care of itself. It's actually a lot harder. I mean, organizations are set up to do very specific things. People complain a lot about big bureaucracies. A lot of the entrepreneurs I work with complain about Duke. Okay, they say that they're not adopting new cutting-edge technologies. It's very difficult to get in. That might be true, but what also is true is that Duke is doing other things very well. And Duke is set up to deliver on particular outcomes. And so you might argue that you might want to change those metrics, but there are reasons why organizations can't be ambidextrous, right? It's difficult to adopt new technology and experiment and also deliver on key metrics at the same time. And a lot of organizations have that problem. The other thing is consent. If you're going to run these experiments, if you're going to run pilots, who needs to say yes? Who needs to participate? Who needs to be blind? How do you even set these things up in an organization? And that, I think, is another big barrier in healthcare. Another thing is how long the studies go for. When I run field experiments with Fortune 500 companies, I mean, we need to run these for a long time to see, impacts on return on investment. Okay, so if you're trying to measure a financial metric, you can't do that in a 3-week study. So running these RCTs or these field experiments over a long period of time requires lots of data and lots of buy-in from the organization. You don't often get that when you're thinking about these things. And what are the right metrics? What strikes me as peculiar about healthcare, peculiar in particular, is that the stakeholders somehow have disagreement over what the right metrics are. And there's a somewhat nebulous term, value, that's being used differently by a lot of different people. I'm not sure that if we don't have the right metrics, it's very hard to agree what the dependent variables are in most of these studies. So the big thing in Silicon Valley right now and across the world now is this lean startup method. And I think you guys have been experimenting with that in DCRI. Basically what lean startup is saying is like, look, don't build your product the way you used to build it, where the engineers build to spec and they send out the product without testing it and they see if people like it. Build a minimum viable product, something that has one feature that you think is really important to the customers, see how customers like it, iterate, send it back out. Iterate, send it back out. So it's basically a way to experiment. It's a very attractive way of developing products because it costs less and it's a way to get products out more quickly. So startups love it. Everybody wants to do this in healthcare. Everyone wants to apply the lean startup method to healthcare. A couple issues though. One is this is a context where safety is really important. It is very hard to experiment and iterate when the people on the other end, right, are people you need to worry about with safety. If I'm trying a new mobile app, right, or if I'm going to a new web page, you don't have those same kinds of issues as you do in healthcare, I think, most of the time. So I worry a little bit about whether we can do these lean startup types of models in healthcare in the same way. Second, we're talking about a B2B sales channel, a business-to-business sales channel, rather than a B2C, business-to-consumer. Critical difference here. Think about those startups that I'm working with that are trying to sell into Duke. They can't just put something together and throw it against the wall, right, and expect Duke to try it and give them feedback, right? They're more worried about trying to impress Duke, right, to use this technology and putting a good foot forward, working out the kinks kind of, along the way, and hoping that Duke will extend the pilot so they can collect more data. It's a very different process than putting up a web page and seeing how many people click through. It's a very different process than building a mobile app with some features but not all of them. And I worry for a lot of startups in this space, they never get past square one because setting up these pilots is very time consuming. I know many of you have probably been on the other side of the pilots where people are trying to pitch you to try new things in a clinical setting. And you're basically getting overloaded with this stuff, right? How many things can you actually try? All these entrepreneurs want to try new things, but they need a partner on the other end. And I've thought a lot about, and maybe you guys will tell me that this is already out there, but could we find a way to systematize or routinize pilots so there'd be a way to understand how to get these things done? Maybe that's something that's impossible, a pipe dream, and you can tell me from the inside. But it strikes me there's a lot of people on the outside trying to get in who have no idea how to do these pilots. And for them to raise their next round of funding or develop their product further, they need data from a real setting. And one entrepreneur, asked me the other day, he said, how do I do this? What's the secret to getting a pilot? And I honestly don't know if there's a playbook. Maybe people in the audience know what that is. It might be personal connections. It might be such a great technology that no one can say no. I want to give this person advice ex ante that can help them, right, rather than ex post rationalization. But maybe we can talk about this now or during the Q&A. The last thing I've been doing a lot of work on is this, and I think this is very pernicious in healthcare, and again, feel free to push back, mismatch between the solution and the problem. And I'm talking specifically about the wearable devices and mobile apps. So here's the way I'm thinking about it. Let me start in education, and I'll get back to healthcare, and tell me if you agree. 25% of our education dollars in the United States of America, according to some estimates, are in special education. But some of the most innovative apps are targeted for the after-school market for gifted kids. So one thing that strikes me is like the costs are being driven by kids who need extra attention of a different kind. A lot of the most lucrative apps are being sold in the after-school market to parents who are trying to get their kid a higher score on the SAT. And so I wonder if there's a mismatch between where the technology is and where the cutting edge is and all the things we're supposed to revolutionize and where the costs are actually coming from and who needs it. Similarly, in healthcare, when I see people running by with Fitbits and other wearable devices, when I see the rapid adoption of these consumer devices, I see people probably, in large part, who are not driving costs in the healthcare system. And I wonder if a lot of the consumer stuff is being targeted at really the place where the cost isn't, and the 5% of people who are driving 50% of the cost may be, and this is my conjecture, among the least likely to adopt these wearable devices and technologies without a lot of prodding. And I wonder if that's the case, if a lot of the hype over how these things are going to revolutionize healthcare has been oversold. But again, if you go to the popular press, if you go to the venture capitalists, the pitch is going to be that these things are going to change the way we deliver healthcare and the way we pay for healthcare. So that's something I've been thinking a lot about, is this mismatch between the solution and the problem, both in what I call eds and meds. So how much experimentation can you do in your organization, right? The baby Bjorn, which anyone who has kids knows these things well, you had to have a minimum viable product, right? And maybe on your own kid and her stuffed animal, you can do this. But how much experimentation can you do? How can you really release a minimum viable product and throw it out there and see what people think without hurting their reputation or even violating the law? And that's a question I think a lot of healthcare organizations are struggling with right now in terms of how much can we experiment, what's the right way to do it? And this goes back to the issue about pilots. If we found a better way, and again, maybe you've already done it and I'd love to hear it, if we found a better way to do pilots, right? And a way where we knew the guidelines up front, where it was clear, where the objectives weren't well understood, we wouldn't have to kind of ask for permission or ask for forgiveness rather than permission. Okay. So even if we knew what worked, okay, I'm gonna jump over that one. Just assume for a second we knew what worked. It's not clear that practices change all that quickly, right? This is the famous data from the Dartmouth Atlas that I'm sure you guys have pinned to your memory. Lots of variation across the United States in terms of healthcare expenditures. And a lot of the reasons is these practices are sticky. And so one thing we talk a lot about in the business schools, even when you know what works, you see that firms still aren't adopting it. There's a lot of productivity differences between the top firms in the United States and the bottom firms. You may argue that knowledge isn't costly. We all know what good management is, maybe. Why don't these poor performing firms just adopt it and they'll be better? Even when we know what works, it's very, very hard to get people to adopt it. And that's holding back a lot of progress in this as well. So even if we were gold standard with our evidence, I'm not sure things would move as quickly as people think, at least evidenced by a lot of recent trends in healthcare. So let me tell you about one program that I've been thinking about. And it was on NPR actually a couple days ago. They've been doing a whole set on this on Marketplace. It's called the Oregon Health Resilience Program, founded in 2011. With a grant from CMMI. I was at the White House when they started the Center for Innovation in Medicare and Medicaid. Really interesting programs, and it really hits right at these kind of topics I'm talking about. So you guys know a lot more about this than me, but my understanding of this is they were looking for a cost-effective way to treat frequent flyers, people who are racking up a large amount of the costs. They added 18 health resilience specialists across 16 primary care clinics in the Portland area. A specialist works with a doctor, a resilience specialist, and you see a picture of one of them. She was highlighted in the piece. And basically her job is to provide a psychosocial lens. And I think of this as like a wraparound service, almost like a social worker, to provide advice and connections to other things. We all know, like from other things, that people aren't always signing up or even know about the things they're eligible for, right? Which is why automatic enrollment in some of these programs can be really important. So this social worker, resilience specialist works with the patients. And they've seen some pretty good effects. 35% decrease in ER visits. And Oliver Wyman, you can always hire a consulting firm to extrapolate how much this would be if we scaled it magically to the entire world, $300 billion. And even in a world of large numbers in healthcare, that's a pretty big number. So you hear these things on NPR, you read about these things in the journals, and you say, wow, we're just a step away. If we can find a bunch of health resilience programs around the country in different areas, we can create a clearinghouse and we can figure out what's the best standard of care in each area, and then we can scale them because, of course, people will follow the evidence. And then you start to get more pessimistic. And there was a pessimistic part of this too. So they interviewed two experts. One is Amitabh Chandra, who's a health economist at Harvard. The other one's Dr. Ashish Jha, also at Harvard. By the way, we need to work more on getting Duke people quoted at these. I don't know why they only found 2 Harvard people. It's kind of ridiculous. But what Amitabh said is this about this program. There's so many things we do in American healthcare because we think they must work. We have incredibly powerful narratives that each of these things is going to generate billions and billions of savings. Every time we looked, and that's probably an overstatement that he would probably agree with too, we found the answer is a big giant zero. But I think what he's trying to do is slow down the hype a little bit and say, look, even these programs we think work, we're not sure. And he looked at the program and he said it's not clear at all that it's really saving money. And I don't know the analysis he did, but he's a renowned health economist, so he's probably serious about it. Dr. Jha says, look, there's almost no interventions we know of that improve health and save money. Again, maybe an overstatement. There are a couple of things we do know. Vaccinations are probably the number one thing. Once you get beyond that, it starts to get pretty tough. So again, I'd love to hear your comments now or later, but if these guys are right, we've been doing a lot of work on this, and if this is still where we're at, I find that sort of interesting. And I find this a puzzle that's a little more complicated than a bunch of venture capital can necessarily solve. But this is kind of an open discussion. Politics can also slow things down. So I worked a lot in Washington, right? And so I saw this firsthand. Even if you know what works, even if you know how to scale it, I mean, look, take, for example, the expansion of Medicaid, right? Regardless of what you think on policy, it's probably not optimal for some states to expand and some not to, right? So it's either a good idea or it's not. And so we live in a state that didn't expand it, but whatever the case is, you see variation in the country about who expanded Medicaid after the Affordable Care Act. That kind of variation also is going to slow down best practices. You saw the same thing in education. We had a program called Race to the Top, which handed out $5 billion for education, educators in school districts to adopt certain practices, okay? A big thing that's kind of getting in the way of that is the Common Core standards. We think we know what works. The Common Core is supposed to outline some of those things. But again, people are reluctant to adopt it because they don't all agree. It could be the same thing with the Medicaid expansion here, as you're saying. And this is, by the way, I mean, again, it's something we shouldn't ignore when we think about health policy issues, because having been there and studied these things and lived it, it's a huge factor on what gets used and what doesn't. So let me show you, this is kind of my favorite chart. This is the US budget. Okay, it's from 2011, but the magnitudes of the pie chart are not going to change. Most Americans, if you ask them what they think we spend money on, and this is people of all education, all political persuasions, most people think that the stuff at the top, education, maybe social science and medical research is really high. They wonder where foreign aid is on this pie chart. They think that I must have made a mistake because foreign aid isn't here, right? Turns out, no, I didn't make a mistake. This is from the Center for Budget and Policy Priorities. The big chunks are Social Security, 20%. Our budget, you know, if you're looking for magnitudes, think between, you know, $4 and $4.5 trillion, depending on the year. Okay, Social Security is 20%, Medicare, Medicaid, the Children's Health Insurance Program, 21%, and defense, 20%. So if you're really concerned about budget and fiscal issues, and this is the backdrop for a lot of our healthcare discussions, by the way, right? Cutting costs, that comes from our worry about our budget deficits. You really can't have that conversation without talking about 61% of the pie. Right, which is on the right. And the other stuff, by the way, under the discretionary spending, that's what got cut when we had this sequester, right? That was education, that was social science, research, infrastructure, et cetera. The stuff on the right, mostly mandatory, okay? So when you ask Americans about this, there's actually a lot of misunderstanding about what the federal budget is made of and how it works. So they ask people, the federal budget is projected to grow sharply. As far as you know, which of these programs is going to increase the deficit the most? More than a quarter said programs for the poor. That's not really right. Medicaid is a program for poor people, but Medicare and Social Security and other ones serve all kinds of people. So that's actually not right, okay, in a lot of ways. Now, it's certainly not the growth rate of Medicaid compared to those other things. Some people got it right with Medicare. Unemployment benefits is not right, right? Social Security is getting close. Veteran benefits, depends how you define them. So most people have a they don't necessarily understand what the big cost drivers in the budget are. And when we're voting and discussing these things, a lot of the things that happen that make it politically difficult, I think, come from that basic misunderstanding. Then, this is the key, I think. This would be my two favorite polls. Should reducing Social Security and Medicare benefits for current and future beneficiaries play a major role, a minor role, or no role in reducing the budget deficit? So 41% plus 36%, right? That's about 77%. That's a large number. Say no role or minor role. We don't want to touch Social Security and Medicare. And it includes basically that big side of the pie. As an economist, you're okay with that. People set priorities. So great. As an economist, we just got to make the pie bigger, got to grow the economy, raise taxes so we can pay for all this stuff. But unfortunately, in poll number 2, now thinking about different approaches, should increasing taxes play a role? Well, 25% say no role and 38% say minor role. So one of the issues that we're having, one of this imperative to cut healthcare spending and looking for this technological fix, is that our politicians, I mean, they're not stupid. I think a lot of people kind of feel like they must be stupid or they're not paying attention. They're paying very close attention to these kinds of things. If there's anything these people can do, they can count votes. Okay, that's rest assured, that's the one thing they can do. And they understand that people like their programs, but they also don't want taxes. So if you have that issue, how can you make these big changes? The only thing you can do, the only thing you can promise is a technological fix. A whiz-bang gadget that's going to change healthcare and education, that's going to get us better outcomes, because everyone wants that, and lower costs. But I'm worried against this backdrop that we're setting ourselves up for failure, that we're thinking that we're actually not going to have to make big trade-offs when we probably will. And that's kind of where I depart from a lot of people who are evangelizing about technology, innovation, entrepreneurship in this sector. I think it's incredibly important. I mean, we certainly shouldn't turn backwards. But to think that we'll avoid making some of those big decisions, for example, about end-of-life care and what role that will play in our healthcare spending, I don't think that technology is going to save us from those things. So that's kind of my more provocative statement from some of the stuff I've been doing. Even if we get this all right, we might raise quality, we might figure things out, but are costs really going to go down? I talked about this before. I'm not sure machines replace people in healthcare. I think that it might create an even more need for expensive human capital. Great for jobs, not necessarily great for costs. Do we identify new unmet needs and new treatments, right? So if you think about all the diagnoses that are going on now, we're diagnosing things we didn't even know about before and creating now treatments for them. And it strikes me that we might have some of that too, and we might drive up costs. I don't know how this story is going to end. I think I'm skeptical about innovation entrepreneurship saving us from making these key decisions that we're going to have to make on the way we pay for healthcare, right? And basically the way we deliver it. I do think that this innovation entrepreneurship kind of narrative should be thought about in this way. In what sectors of healthcare will it be most effective, right? What treatments of diseases, what kinds of patients will it make most of the difference? And within that, what kinds of applications, software, hardware, right, EHR, whatever it might be. For which patients? Are we talking about people who are already really healthy or people who are very sick? Where are we going to start? And can we design institutions to make this process work better? Because adoption is slow and messy and political. And I wonder if there's a way for us to do better on some of these things. So I'll give you one example, and I haven't figured out how to do this in healthcare, but in education. So in educational technology, if anyone's ever bought an app for their kids, really it's hard to know what works and what doesn't. There's no FDA, not even a Consumer Reports really for ed tech. And so what happens is you just adopt whatever the popular app is, and it could be completely counter to educational principles, but your kid likes it. And engagement and marketing dollars is used to drive this. What we've done is we said, look, one of the issues with educational technology is that no one knows what works, so parents can't make the right investments. Schools can't make the right investments. And basically, it's dominated by 3 big players who have huge marketing budgets and big sales forces, right? Companies like Pearson. So one thing you can do is set up a nonprofit entity that would actually test and rate these apps. So what we did is we set up a nonprofit called EduStar. We test the educational apps with RCTs in real schools. We test it against the Common Core standard. So the Common Core standard might be a child should be able to count to 100 by 10. Let's suppose I invent an app to do that, and Eric invents an app. We put them at head-to-head RCT trials and against a control. We see which one actually affects the ending test score better during that period, and we give them star ratings. And so when parents and teachers and students themselves can look at these apps, they know what works and what doesn't. It's a Consumer Reports for educational technology, and our hope is people will use this as an entry point into selling and also a way to prototype products. I wonder, and maybe there are already things out there, if there are things to do on health apps. I know a bunch of doctors have websites where they review health apps. But it'd be really interesting if there isn't already to see better data on that so we can actually figure out whether the thing I'm downloading that goes in my Fitbit is actually proven to do anything. Whether it's an evidence-based diet or an evidence-based exercise regime, or whether it's better than what I'm doing already. Because without that, we're just a prisoner of millions of these apps and word of mouth, which I think is really inefficient. So the other thing that's going to be a priority for me in my outside work is thinking about what these institutions could be to make this process better. Okay? So who has the best chance of getting all this right and creating a breakthrough? And this is what I talked about at the Q-Core conference that Eric and Adrian invited me to. On one hand, you might say it's you. You guys are looking in the mirror. You're the closest to the unmet need. You have the accrued experience. You're motivated to solve a clinical problem that you actually encounter every day. And you're not looking necessarily to build a business in most cases. You have the credibility. You have the professional social networks. You understand the workflow inside these organizations. And you know how far we can deviate from the status quo before things break. So in some sense, we should be looking to you to do the innovation and entrepreneurship. Or maybe not, right? Maybe you're exactly the wrong people to do this. This is the other side of it. Maybe you're constrained by traditional training, career ladders, groupthink. It's very difficult to basically try to make yourself obsolete, right? When people think about new innovations, like would I ever invent a MOOC? No, probably not, because what would you need me to teach business school students for, right? So it's the same thing. You worry about whether or not existing organizations are where it's going to come from, right? Probably it's a combination of both, but this is the debate that's going on right now. Okay. So a couple last things on entrepreneurship and innovation. A lot of people come to me who are physicians at Duke or other sort of scientists at the university and say, I want to think about entrepreneurship. I want to commercialize my research. So to the extent that's interesting to people in the audience, starting a company is at one far end of the spectrum. There are lots of ways to be entrepreneurial short of starting a company. And for those of us who actually like our day job, I don't think we should think that dabbling in entrepreneurship is something that's likely to be successful. So I think people should look at a bunch of different things. One is being a founder, fine. You can also be a joiner. You can join these startups at later stages when there's less risk in a clearly defined role. Joiners are just as important as founders, sometimes more so. Scientific advisory boards, I'm sure it's well known to people here, but that's a great way to contribute. You don't need to be a founder and the next Mark Zuckerberg to make an impact in health innovation. You could be on an SAB that makes a big difference. Testers, consultants, other kinds of role. I'm going to pivot now to talk a little bit about what happens when you take these roles, which is the discussion about conflicts of interest, where I've done a lot of academic work on. There's all these trade-offs between those with expert knowledge often being those who have the most to gain. And we see this in government and in academia and in the private sector. So one of the things Senator Elizabeth Warren has been talking about is who we appoint to be our regulators of the financial system. Turns out a lot of people who know the inner workings of Wall Street work on Wall Street. And it turns out a lot of people who work on Wall Street and want to go to government want to go back to Wall Street. I mean, that's natural. I started my career at Goldman Sachs. I know how that is. The problem is, right, if we only can choose from a pool of people who worked on Wall Street to be our financial regulators, you might wonder if we're going to get the right kind of financial regulation. But as Lisa Rosenbaum is pointing out in her New England Journal piece, which is pretty controversial, she's saying, look, just because someone is conflict-free doesn't mean they don't have their own bias. So how should we think about conflicts of interest and expertise in the same way? So that's been what a lot of my academic research has been about. Let me run through that quickly because I think I can stop maybe in 5 minutes for some questions. So when I think about innovation and conflict of interest and really get deep on this thing, I have 4 published studies, 1 ongoing, mostly focused on medical devices and pharmaceuticals. The first set of studies are all on medical devices. One of them is in health affairs, which I can share with people. I think it'll be a good introduction to all this work. The key question I'm asking is, what is the trade-off between conflicts of interest and inhibiting innovation? Innovation, the whole story of innovation is people working together, breaking down boundaries, having people from different disciplinary backgrounds and people from different parts of the economy getting together. But if you can't have people working together without worrying about conflicts of interest, it's going to be very difficult. So let me tell you how we built a data set to kind of look at this. So we took all the patent data from the USPTO. That's about like three some odd million patent records. List an inventor name, the company that owns it, the characteristics of the invention. We took that and we matched it to the American Medical Association membership file. I know there's lots of professional societies and other things. We started with the AMA, okay? Name matching, it's always sad when a year of work is, 1 bullet point on your slide. Name matching is really difficult because there's many Eric Petersons. There's even many Aaron Chatterjis. So matching this Eric Peterson to the right Eric Peterson on the patent is actually not straightforward. So we use Eric's middle name. We use co-authors that Eric's worked with in the past. We use his location. We look at his website. We try to find anything we can to triangulate this, and we do a bunch of fuzzy matching techniques to make sure we get a decent match. Lots of details if you want about that. Once we know who the doctors are in the patent database, we can tell you for the first time ever what percentage of medical device patents come from physicians. The answer is about 20% of all medical device patents in our sample period have a physician inventor, okay? We then look at the FDA data. We match that to the companies that the docs work with. So Dr. Aaron Chatterji, listed on an inventing patent. He is a doctor in the American Medical Association. He works with Medtronic. We can give you all of Medtronic's product approvals and through 510K and PMA. We then link all the financial data using a database called CompuStat, so we know everything about Medtronic and every other firm in the industry, in addition with private firms. For our pharmaceutical data, we worked with a company called Kairos. Kairos took basically disclosures that companies like Merck and Pfizer made online about their payments. A lot of these were results of deferred prosecution agreements. Kairos cleaned up all these. They did the Eric Peterson match that we had to do ourselves with the patent. And they also checked it against, and we've checked it against the CMS open payments data and state databases. So now we know who Pfizer's paying and whether they're paying them for meals, for research, any other kinds of activities. We then matched the Chatterjis and the Petersons of the world to academic publications and other scientific activities. So essentially, we have a huge data set that starts with the individual, links them to a company that's either paying with them or working with them in the patent, and then links it to all the company performance data. Now, before you get worried, we're not going to do the silly thing, which is saying that Aaron Chatterji got paid $1 million by Medtronic, and he must be biased, he must be on the take. That's exactly the wrong thing to do, right? There's a huge difference in this case between correlation and causation, right? So what we're going to try and do is tease some of those things out. So let me just tell you the highlights, and then maybe I can take some questions. I could skip this. Basically, this is telling you about patents, and there's a lot of medical device inventors who are doctors. Let me just tell you about the patents, what we find. The patents tend to be the doctor ones. They're the most cited patents. They're the most likely to spark follow-on innovation, and they're the most likely to build on a diverse set of prior knowledge. Basically, on all our indicators, the doctor patents are much better than any other patents in the medical device industry. So not just are they 20%, on all the patent indicators, doctors are doing the most valuable stuff in the medical device industry. And that doesn't surprise you, right? Because a lot of the work in medical devices is tactile, right? It involves using the device, figuring out ways to make it better, and taking feedback from that. And that's why a lot of orthopedic surgeons are inventing great orthopedic devices. A lot of cardiologists are inventing great cardiology devices. Companies use collaboration to access these kinds of knowledge. When they work with doctors, we find they get more product approvals by the FDA, particularly in new technology areas. So we can show you that working with doctors actually has a benefit. So first we establish that the incidence of innovation is really high among doctors in devices. We then show you that that knowledge is really valuable, and then we then show you that companies that work with doctors are using that valuable knowledge and translating it into products. It's a virtuous cycle in that sense. But, right, and I'll skip over these descriptives. These are showing you where the inventions are. Collaborative innovation in the device industry is pretty controversial. Okay, not everyone thinks this is a good idea. So Medtronic thinks it's great, right? The medical device industry is unique. The products we develop and manufacture cannot be invented by trying a new formula in a lab like the pharma industry. They always like to take a dig at the pharma industry. They must be designed and produced in close collaboration with the men and women who will use them, the world's most highly skilled and innovative surgeons and doctors. That reflects what we're finding in our data. But there's a lot of critics. Jeffrey Kahn, right? Bioethics at Minnesota. Surgeons tend to choose one brand or device or another. It's not like you get to pick for different brands, like you're shopping for a car. You go to one doctor, they use Stryker. You go to another one, they use DePuy. Why? Often because they have some sort of relationship. He's basically ascribing the correlations that you'll find in these data to causation. That basically getting paid is going to lead them to recommend the device. Now, remember, the alternative could be there's a small set of great doctors who are doing cutting-edge research. Everybody wants to work with them. Their time is valuable. They get paid, and they pick the device they think is best. Right? There's alternative hypotheses, but this Dr. Kahn thinks that this is the issue here. Now, you have an issue in orthopedics specifically, which we've done a lot of work on. A small number of orthopedic docs do a large number of the procedures. So there's a lot of competition for a small number of people, and the switching costs are pretty high between different, like let's say, knee replacement systems. So once you lock in a doctor, right, it's harder than in other areas, like I would point to some other parts of medicine, to switch. So this leads to a lot of competition and aggressive, sort of payments from orthopedic companies. So this is what we've been looking at a lot. Okay, let me take one more minute because I do want to leave some time for questions, and I can show you guys some other stuff. Let me just show you one thing. So we basically use this lawsuit from the Department of Justice. To recap really quickly, the DOJ basically sued 5 big orthopedic companies over these kinds of relationships, saying that it violated the Medicare kickback statute. The idea is I can't pay you, and then the quid pro quo is then you prescribe my device and get paid under Medicare. So what we do is we basically show that the FDA approvals for the companies that were involved in the suit after 2005 go sharply down, and the dotted lines represent 2 kind of control groups. One is an orthopedic firms that were not involved in the lawsuit, and you see their FDA approvals going up. And then you also see a flat line, which is cardiology firms who are not affected by these particular lawsuits. So we use 2 different kinds of controls. Bottom line is the lawsuit made it harder for doctors and companies to work together. Ergo, it was harder for that set of companies to develop new FDA product approvals. The whole line of research here is trying to show that the channel between doctors and companies is really important for innovation. And when you cut off that channel, you're going to see real impacts on products. Now, I can't tell you that all these products are going to be valuable from a social welfare perspective. Maybe you think we do too many spinal fusion surgeries and we just got less of those and that was a good thing for social welfare. I can't tell you that, but I can tell you that we have less FDA product approvals. And I can tell you that they came in areas where they worked a lot with doctors. So the question now in our future research is trying to figure out how to quantify the costs and the benefits. And so now we're trying to do that in the pharmaceutical industry. So let me show you one more slide about this in pharma, and then I'll open it up to questions because I've taken too much time already. So here's pharma. Do payments from a pharma company equal biased treatment decision? It's the same question. You might argue that it's a little bit different here because that whole angle about user innovation, giving someone a pill, again, I'm not a physician, seems different from using a device. So one would argue maybe the benefits of collaborative innovation are different in devices than drugs, but let's talk about that. The key results so far, it's a really small fraction of doctors who receive large payments from pharmaceutical companies. We're talking 1 to 2%. This isn't like a general problem that you should be thinking about. There's a positive correlation between payments and doing branded prescriptions in our data. And that's data from 2010 to 2013, okay? Not necessarily causal, not necessarily causal. It doesn't mean that people are getting paid and they're, that's not what that says. There's just a positive correlation. There's also a positive correlation between payments and academic research. Again, right, you might just be paying the people who are at the top of their field, right? Because they're at the top of their field, they have the most knowledge. Rosenbaum, I hope most of you have read it. If you haven't read it, you should read it. It's causing a lot of stir in the New England Journal on this topic. So we focus on psychiatrists, and I'll just tell you the quick results. Why do we focus on psychiatrists? Because we have complete data from Pfizer, Lilly, and Forest. As far as I understand, they're 100% of the branded prescriptions with SSRIs and SNRIs, so Prozac and related drugs. We also have the Medicare D claims data. Okay, we have payments for meals, speaking, research, and travel payments. So what we're finding here is the following. 2% of psychiatrists are really publishing at the top of their field. A physician receiving 10,000 or more is 3 times more likely to have a publication in a top 100 journal. So the people who are getting paid a lot of money are people who are more likely to be the good publishers. A physician receiving 10K or more is 43% more likely to prescribe a branded drug compared to the rest of the sample. Again, that's correlation, not causation. A couple things we're doing here. We're looking at within doctor variation. So let's suppose Dr. Chatterji gets paid $15,000 in 1 year and gets $30,000, the same doctor, the next year. It'd be much better to look at the changes in Chatterji's branded prescription than Chatterji against Hernandez, right? Because there could be lots of unobserved differences between the two doctors. When you look at that, it turns out that it is consistent with more payments leading to more branded prescriptions so far. So that's suggestive of more of the causal channel. The other thing is payments are for different things. Non-research payments are correlated with branded prescriptions. Research payments are correlated with research only. So it appears both in devices and pharma, what you're getting paid for, IP research, is usually correlated with what you're doing. The meals, the travel, and the speaking, not correlated with research, but correlated with the branded prescriptions. We're looking at the AMSA scorecards now. We're hoping that we can get variation across different medical schools, conflict of interest, and then we can use that variation to tell you something more about the impact of getting paid on these kinds of outcomes. For me, the big question is, what's the trade-off between conflicts of interest and innovation? Innovation requires people to work together across boundaries. When people do that, conflicts can arise. Clearly, we show you in devices and in pharma, there's some advantage of working together between companies and doctors. There also could be potential conflicts. How do you think about regulating these things so we get the right amount of innovation, but we also don't get biased treatment decisions? So that's kind of the little picture topic inside innovation that I've been spending most of my time on. Let me stop there. I can take the last 5 minutes or so for questions. And if we run out of time, to respect everyone's time, we can close at 1, and then I can take some questions offline. So thank you. Go ahead, yeah.
Hey, Ronnie. So a suggestion and also a question. So one thing that you could also look at is the space of interventional cardiologists for conflicts. So I think you find a lot of conflicts there, and so without a lot of evidence in terms of therapies. But we'll leave that to another day, and maybe Manesh will be able to help you out there. But one thing that I always leave somewhat disturbed when I hear you talk is the potential issues about healthcare innovation. So if you see, like, from accountable care organizations essentially becoming a more consolidated healthcare system, or payers, I mean, now that's in flux with the big 5 potentially going to the big 3. Yeah. And then electronic health records and health IT, where there's a big monopoly with Epic, especially for large academic medical centers. How do you see that as playing an issue for healthcare innovation?
It's a great question.
Is it?
It is. It's a great question. So economists spend a lot of time studying the impact of competition on innovation. And what you're describing, consolidation in the payer market, with the EHR sort of market structure, that will have an impact on innovation, right? So that a lot of studies we've done in other areas show that. These results tend to be somewhat more mixed than you might think, but in general, we think that more competition is better for innovation. Why? Because if you're a monopolist, you have little incentive to invest in new technologies, right? You have a captive market. It's very difficult for someone else to come in. So why use that extra money into R&D when you could be using it, right, to pay out shareholders or executive salaries? That's like an idea. On the other hand, there's other industries where monopoly structure also allows scale to test out new innovations, and you see that people actually see more innovation coming out in those industries. So it's kind of a mixed story. I'm worried, though, in this particular area because of other reasons, that sort of consolidation and sort of a more concentrated market in those areas is going to reduce innovation. Primarily because I think it's an incentive story that's going to dominate here. So I think it is a big concern. And I think, though, that the antitrust regulators, when they look at these kinds of deals, will take this into account. They're supposed to do an analysis that will capture these kinds of things. That's what the DOJ competition unit is all about. So I think it's a good thing to worry about. People will be looking at it.
You put a lot of excellent stuff out there. You can have job-rich profiles and machine-rich profiles. A job-rich profile will return to society a lot of values that a machine-rich profile won't, because people have a job to go to, they have meaning and purpose in their life, and they pay taxes.
Yep.
So there are all kinds of good stuff from a job-rich profile that you may not, and so in your economic summaries,
right,
you have to include a lot of outputs that aren't simply the economic output within the industry, but the social consequences of the strategy.
Definitely. So, traditionally economists thought about technological innovation as follows. Like, we used to wash clothes by hand and hang them out to dry and have a washing machine. So the issue is that you could, instead of doing that work, you could basically free up time to now go and do another job that's more productive and more satisfying. So some of the technologies early on freed us up, right, to do these things that we couldn't do before. But at some point, right, I think your point is, what if machines make us obsolete? What if there is no other higher productive thing to do? And what if we lose our purpose? Because manufacturing specifically, it's an area I've learned a lot about. When people lost their jobs, right, the notion of being able to make things that actually went into these large industrial projects, for example, versus a service job now where they feel a lot less satisfaction, even if the job paid the same and it often doesn't, the satisfaction wasn't there. So you may be able to put people in different jobs, but the question is whether they'll get that purpose and meaning out of it. And so these are open questions. Economists, frankly, are not great at studying this stuff because it's hard to measure. But a lot of us, I think, are waking up to kind of interdisciplinary research with other people who are interested in those kinds of things. It's not captured as much in the GDP statistics as people would like. There's alternative measures that people are looking at to try and capture some of these things. So I'd say, especially the younger economists, cognizant of it, hard to operationalize, but we try not to forget about these things when we make policy recommendations. And you've seen that in the manufacturing policy area specifically.
Time for one more?
Sure.
I really appreciated some of your early comments about disruption and complex organizations, and then also sort of that balance in a industry like ours between sort of needing that proven excellence and then also being willing to take chances.
Yeah.
And those don't always fit together really well. So within that context and in your experience out in the world, what are some of the cultural characteristics of organizations that do it well?
Yeah, I do think it's cliche, but leadership really matters. And people need to know that they're going to be covered if they make a mistake, right? It's interesting when you decentralize power and say, okay, you go off and make your own decisions. But what happens when you make those decisions and there's blowback, or you get slapped on the wrist and people say, well, we just set up this skunk works, we did this innovation retreat, every time I try to do something, right, I get in trouble. Or if there's no time to actually do the innovation stuff because you have 110% of your job.
Right.
So I think it does, the organization do this well, the people at the top really believe it and they're going to put credible commitments behind it. And that's hard to do because look, a public organization, you have shareholders to deal with and quarterly results. I mean, this is a huge, and this is a harder business environment that's been a long time. So that's one thing. The other thing is I think it starts in the hiring, right, and what you reward at a very early stage. So, what I found, I was in government for a while and people always said, you should make government more efficient. You should do X, Y, and Z. And you know what? The people who worked in government, who have been there for 30 years, they took the job when there was a certain job description. And then now all of a sudden to expect to change the incentives and expect the people who are working there now to change in response to those incentives, that's sort of like probably unrealistic. It'd be easier if you hire new people in who actually select into the organization you're trying to create. Obviously that's difficult in government, although there'll be opportunities for that as a generation retires. In a new organization or one that's building, that's the other area you can think about. The other place that people are doing stuff, they're setting up innovation centers, they're setting up units to do this kinds of things. There hasn't been a study that I've seen that's convinced me if it works or not. It certainly is the vogue now to basically do these kinds of things. And the idea is to free up a bunch of employees from their existing jobs to kind of think big things. Depends how much buy-in there is from the CEO, the head of the organization, because those things can also flounder. You've seen some organizations, I would recommend if you're interested in healthcare, and a lot of you know probably a lot about dialysis, so DaVita Healthcare is one where they've also had some pretty successful sort of things with their entrepreneurship efforts, which I would kind of put akin to this. So if you see like DaVita RX was basically like captive pharmacy for DaVita dialysis patients. They've also started it's a freestanding clinic. I can't remember the name. It's like Palantir or something like this, where they have another business they've started inside DaVita. They've done well, but they have Ken Theory at the top, who is very committed to these kind of things, and he kind of watches over these things and gives people cover. So those are kind of the factors I've seen like in the real world of what works and what doesn't. And academic organizations are different also than business organizations. So at Fuqua we think about this all the time, but we have different constraints. Right? All right, well, if there's any more questions, you can reach me emails, Twitter, and you can also come up afterwards and chat for a little bit. Thank you.